So many people still are not getting vaccinated. To talk more, let's bring in Dr. Nigel Paneth. He is a professor of epidemiologist and biostatistics and pediatrics over at Michigan State University. Doctor, great to have you with us. How are you today?
Great to be on your show. Thank you for inviting me.
So I'm hoping that you are waking up indeed with electricity and power at your home.
Well, I'm actually not in Michigan at the moment, so we've had no difficulties.
Well,
I'm in the state of Vermont.
Oh, well, good. So you guys didn't have the storms that we had over the weekend.
No, we didn't. Perhaps they'll hit us later.
Well, let's hope that when you return to your home, but it does look like the Lansing area was spared. It was more Genesee County and northern Oakland County, that everything is good at your home. Doctor, if I can talk to you, because can you just give us an overall feeling as someone with your medical background and your training, where we stand in this pandemic?
Well, we've made great strides, clearly. We've vaccinated about half the U.S. population, but it's by no means over, unfortunately. I wish it were the case, but because we still have a substantial fraction of the population unvaccinated, it's going to be hard for us to bring this to a close. It will, as long as there are unvaccinated people, then you still have the potential for epidemic spread. And that's the sadness, is we now have a great tool, an effective vaccine, and yet not everybody's picking up on it. Michigan's a shade ahead of the nation. We have about 53% of the population vaccinated. Nationally, it's closer to 50%. Oakland County, I just looked at the data, we're over 60%. So we're getting there, but we're not out of the woods yet, and we won't be out of the woods until we have a very high fraction of the population vaccinated.
So as someone who studies this, what is that magic number to try to stop this, that we can get back to life as normal and not have COVID-19 be in the headlines every day?
Well, it's difficult to give one number because every virus probably has a different threshold. This is, especially the Delta variant, is very communicable. And as the communicability increases, the so-called herd immunity, the fraction of the population that has to be immune to keep things, epidemic spread suppressed, gets higher. So I think most of us would be happy if 80% of the population were vaccinated. Remember, children not yet being vaccinated, small children under 12. So they represent a potential pool. They're not likely so far to, they get sick rarely, but they can still transmit to people who can get sick. So I'm hoping the development of the approval of a child vaccine, which I anticipate will happen in the next few months, will help a lot. But there are a lot of people quite eligible, and all they have to do is get a shot. That's it. And it's not just about yourself, when you get a shot. It's about the whole community, because you protect yourself, yes, from severe disease, no question, but you also protect people who are more vulnerable than you are. That aunt of yours who's on cancer chemotherapy, that cousin who's had a kidney transplant, these are people who don't form antibodies very well. And anyone walking around unvaccinated today in an area where there's a substantial amount of transmission is just a walking time bomb for somebody else, for somebody other than themselves. So if you don't want to get vaccinated for yourself, maybe do it for your friends and relatives and people you may not even know who are more vulnerable than yourself. Try to prevent transmission.
Doctor, I'm sitting here listening to you, and I feel like if we would have had someone such as yourself as part of the PR campaign from day one, we'd have a lot higher vaccination rate than what we have right now, because you just explained it so beautifully. Well,
thank you very much. I have to say I'm old enough to be part of of a generation that recognized vaccines and what they did. I mean, when I was a child, there were kids on iron lungs from polio. And you did not want to have your child on an iron lung with polio. And I've seen measles put a child into permanent coma. I've seen whooping cough cause a stroke in a 9-month-old. I mean, I've seen these things. And I was in New York when 2 kids died of diphtheria, not in my hospital, but in another hospital. And, you know, these things burn into you, you know, and you say it's so simple to prevent them. When I was in the 60s, as recently as the 60s, the 70s, you could not come to the United States without a yellow card that showed you'd been vaccinated against smallpox. And it was understood. We were not going to let smallpox into this country. And in 1978, smallpox was eradicated through vaccination. Eradicated completely. This is a disease that killed 1 million people a year, as recently as the 1950s in the world. Eradicated completely. We haven't had a case since 1978, 40 plus years. And I don't understand people who don't get that, you know? Where's the smallpox? Where's the polio? Where are the iron lungs? They're gone. They're gone because of vaccination. And people are saying, oh, this has been rushed out. Let me tell you, I've studied the 1954 polio campaign, vaccine study which was done, by the way, the big study was run out of Michigan, run out of Ann Arbor. The University of Michigan Department of Epidemiology ran that famous study, 1 million school children. That study was done just as rapidly as the studies we're doing now. The polio vaccine was being used with no more evidence than we have now for the COVID vaccine. In fact, the polio vaccine trial showed it to be less effective than the COVID vaccines are now. COVID vaccines are 90 to 95% effective. The polio trial showed the vaccine to be 80% effective. And we just forget the lessons of history. So, you know, if you forget the lessons of history, you repeat history, unfortunately.
Dr. Nigel Paneth with us here on the MegaCast. He's a professor of epidemiology and biostatistics and pediatrics out of the Michigan State University. And doctor, what is it going to take? Because as you mentioned, to travel into the U.S., you had to have a vaccination card. I went to Africa a few years ago. We had to have numerous shots, and we didn't think anything about it. It was like, in order to travel, these are the shots and the vaccines that you need to get to be able to get on that plane. So what is it going to take for us to get today's society there?
I wish I knew the answer to that. That's a question beyond medicine, beyond epidemiology. It has to do with the way people think, the way people believe. I really do think that the success of vaccines have blinded us to the success of vaccines. You know, it's because we eradicated those diseases. My parents, probably your parents too, grew up with the idea that children were vulnerable to diphtheria, to whooping cough, to polio, to many other vaccine preventable diseases. Measles, severe measles. Measles killed 500 kids a year in the U.S. before we used the vaccine. Of course, 500,000 cases a year. It was, you know, people forget how severe these things were. And since we don't see them, we kind of say, oh, well, we don't need to worry about them. But of course, the reason we don't see them is because we're vaccinated. And the tragedy is that people don't seem to understand that. And I really honestly, I've asked myself the same question that you just asked me. What will it take to get people to understand how valuable this measure is in general and specifically for COVID? And I don't have an answer. So, I think you have to ask the people who are not getting vaccines, what would convince them to get vaccinated?
If I can ask you, Doctor, as someone who studies this, did you anticipate that we could be exposed to a pandemic such as the one that we're experiencing now? Not necessarily COVID-19, but as an epidemiologist, did you foresee this in our future?
Well, epidemiologists have been thinking about the possibility of a new bad epidemic for a long time. We particularly worried about influenza. We remembered the 1918, 1919, 1920 influenza, which killed, the general estimate is 50 million people around the world. And it killed a lot of young people, unlike COVID. It was especially focused on young people who got it. And we've been kind of waiting for that other shoe to drop, the next big flu pandemic. It hasn't happened. We had examples of it, you know, H1N1 and the various other We got SARS. SARS was a wake-up call, you know. It went through Canada. We didn't get much of it in the U.S., went through some of the Far Eastern countries. We're always kind of on the edge. We don't monitor as tightly as we used to our borders for incoming infections. You know, you couldn't come into the United States as an immigrant without a chest X-ray that was free of tuberculosis. You couldn't come in without a vaccine card against smallpox. We had 55 quarantine stations in the United States in the 1970s. Those were, we kind of shrugged our shoulders. We felt we didn't need them. They've been removed. We don't have those anymore. So we've become a bit, frankly, lax, and we've let our public health infrastructure deteriorate, and we haven't invested in this, and that's a very sad thing.
Dr. Nigel Paneth with us here on the MegaCast. He's the professor of epidemiologist, biostatistics. I have only had one cup of coffee today.
I know.
And pediatrics over at the Michigan State University. And with that, I know that you wanted to talk a little bit about some of the treatments for people that are exposed to COVID. Can you explain more about that?
Well, we don't have any single magic bullet for COVID. We've learned a lot of last year about the right way to treat very ill people. I think one thing that doesn't get emphasized as much as we might be able to emphasize it is the use of what are called passive antibody products. The best known of those is the monoclonal antibodies. Those are licensed for outpatient use. They're very effective. They prevent people from getting severely ill once they're infected. Similarly, convalescent plasma, which is not yet authorized for outpatient use, I wish it was, unfortunately, it's not, probably should be given to anybody who's not desperately ill when they come into the hospital, because it really can prevent progression to severe disease. This has been demonstrated in a very good randomized trial in Argentina, and convalescent plasma and monoclonal antibodies can reduce the likelihood that if you're sick with this disease, you will progress to being on a ventilator or being in the ICU. So I think and it's very important that those be done in the early stages of the illness, not late. Late in the illness, they're not going to help you at all.
So when we say early stages, can you give us a timeline? Because we do know what the incubation period is, 7 to 14 days. So by the time someone tests positive, is it that day they should start their treatment?
I would count from the days of illness. Once a person is ill, I would say it's ideal to get monoclonals into them in the first 3 days, 4 days. If they're very, you know, and who would you use it? You use it particularly, these treatments, in people who are at risk of becoming severely ill by dint of age, by dint of underlying conditions and things like that. And then I think, but if someone's severely ill enough to be admitted to hospital, then I think it's very useful to give convalescent plasma, because I think the bulk of the evidence suggests that treatment of people early in the course of illness with convalescent plasma is helpful. And unfortunately, we've had some trials done in people who are very sick, very advanced disease, and it's not helpful then. And as a result, some people think it's not useful at all. It's just useful in the early stages of disease.
So is this something a patient would have to ask their doctors for, or should it just be administered immediately?
Well, it might be of value to remind people the use of convalescent plasma peaked in the U.S. in the last fall, and it's dropped off quite a bit since. And so doctors may need to have to be reminded about this, and of course monoclonal antibodies. Now, both of these require intravenous therapy, so it's not like a drug off the shelf that you pop in your mouth. So it's a little more complicated, but I still think it's really ideal to have, even if you can't reduce the burden of infection, perhaps you can reduce the burden of progression to severe illness and not have the consequence of being in ICU, being on a ventilator, and dying.
So I know that, the convalescent plasma was talked about a lot back in the beginning stages, well before the vaccine. And then it's like you said, that conversation has waned off quite a bit. Do you think that's also impacted the amount of people donating their plasma?
Yeah, we've been, you may not know this, but I've been involved in the National Convalescent Plasma Project, COVID-19 Convalescent Plasma Project, and we have been first studying and ultimately beginning to advocate for convalescent plasma use early. And there was a drop-off in use in November, December last year when one or two trials came out that showed it wasn't reducing the death rate, but those trials were conducted in people with very advanced disease when we don't think that's the right time to do it. So it was kind of the wrong experiment. The trials that started early showed much better results, and so we think it's a useful thing. It's very safe. There are very few side effects from convalescent plasma, and if it were available, I would recommend where authorized for outpatient use, I'd recommend it, but it's not yet FDA authorized for outpatient use, only inpatient use. So I would urge people to get, if they're admitted to hospital, to tell their doctor, would you please consider convalescent plasma for, as soon as possible. If the doctor doesn't know about it, I'd refer them to our website, ccpp19.org, ccpp19.org, which is pretty comprehensive in its treatment of what the evidence is for convalescent plasma. All the trials are there, all the information any physician would need to think about treating with convalescent plasma.
So, Doctor, just another minute or two here with you on the MegaCast. So if we can, what is the time frame and who can donate their plasma for it to be utilized? Do they have to be infected with COVID-19?
Yeah, the idea is you are taking a product that contains antibodies to COVID-19, so it has to come from someone who has been infected with it. There are conversations now about whether vaccinated people might be a source of convalescent plasma. That hasn't been resolved. So right now, we're using people who are sick with it. And it's ideal to have the level of antibody tested because people vary in how much antibody they produce. And you want to use high titer antibody product. And in fact, the FDA has actually given a threshold above which, you should use the antibody, the plasma antibody level is going to be effective. So I hope blood banks are all into this. We've had many conversations. We're in touch with the AABB, the American Association of Blood Banks, and many other good organizations, Red Cross, Vitalant, many of the providers of plasma, and they are ready for people to give donations, and they can. There's even actually I'm pretty convinced there's a backlog of available convalescent plasma in the United States that can be used.
Again, we're talking with Dr. Nigel Paneth here on the MegaCast. He is a distinguished, it's one of those days for me, it's Monday, professor, epidemiologist in biostatistics and pediatrics over at Michigan State University. Doctor, it's always great talking to you. Thank you so much for your insight and your knowledge. I learned so much in our conversation, and I have to say we've been talking about this for more than a year, and you've offered new insights, so we appreciate it.
Thank you very much.